Good morning, everyone, and welcome to today's CEAL Healthy Longevity webinar series. My name is Jocelyn Protopappas, and I'm the Manager of Special Projects at SDSU's Center for Excellence in Aging and Longevity. I'm really excited to have all of you here today for a topic that I think is going to be both thought-provoking and inspiring. We are going to talk about the importance of proactive decision-making when it comes to dementia and end-of-life care. When we think about long-term planning for our futures and for our older selves, we often think about retirement, maybe finances, that vacation we've all been eyeing up. But some really important questions often get left off the table in these long-term planning sessions, including things like, what do I value most in my life? If my memory or cognition start to fail, what are the things that will help me live the best life that I want to live? And who do I trust to speak for me when I can no longer speak for myself? Yes, these conversations and questions are often difficult and hard to have, but they're critical. When our family comes down to having to make decisions for us, it can often ease the burden and the stress if they know our best wishes, or they know our wishes in advance, excuse me. So today we are going to be talking with our special guest about two very important decision-making tools. One being the Dartmouth Dementia Directive, which is a tool that families and individuals with dementia can use to make their wishes known before dementia progresses, and an introduction to medical aid in dying. We'll talk about what it is, where it's legal, and how it differs from hospice and palliative care. Our goal today is that you will have some extra tools in your toolbox to help you have informed discussions with your loved ones and make informed decisions. Before we dive into our topic today, I just want to go over a little bit of housekeeping. If you would like to ask our guest any questions, please feel free to either use the Q&A button at the bottom of your Zoom screen, or you can put your questions in the chat. We will save all questions until the end of the presentation. Today's webinar will be recorded. So if you missed any part of it or you want to go back and watch any pieces, it'll be available on the CEAL website. And finally, we ask you to, I already said the part about the chat, so never mind. I want to ask you all to help me give a warm welcome to Dr. Mitsuo Tomita. Dr. Tomita completed his MD degree at the University of California in San Francisco. He then completed his residency in family medicine at UCSF Fresno Family Medicine before he joined Kaiser in San Diego. He's now a retired physician, and he is a volunteer with Compassion and Choices, a national nonprofit that promotes end-of-life education and choices. So please give a warm welcome to Dr. Tomita.
Thank you, Jocelyn. I'm delighted to have this opportunity to talk about, I think the title was Navigating Complex Care Decisions and Dementia Directives. As mentioned, I'm a retired family practice physician. I also co-chair the San Diego County Medical Society's Bioethics Commission, and I've been on the Bioethics Committee at Kaiser for a number of years. So let's get into this. Advanced care planning, it's always too early until it's too late. And even though advanced care planning has been out there for several decades now, the majority of people never do this, even seen older folks. So the advantage or the goal of advanced care planning is to help, again, the family and the care team, the healthcare team, understand what your wishes are for medical care and what you consider to be an acceptable, this term, quality of life. And I think in terms of quality of life, which again, goals of care, all those sorts of terms, what does that mean? And I think they mean, what do you fear and what do you hope for? Well, who decides has been difficult. It's no longer the physician that decides. That's certainly clear. Back in 1975, Karen Ann Quinlan was a 21-year-old who went to a party, drank some alcohol, took some Valium. She got very sleepy, ended up falling asleep, and then later discovered not breathing. She was put on life support as a ventilator and IV fluids. And after several months, her parents asked her to be taken off life support. This was considered against medical advice. it went up through a whole series of legal sorts of things. The parents, by the way, were Catholic, and consulting their priest, the priest apparently indicated it's okay. And there are the ERDs, the ethical religious directives of the Catholic Church, that says overly burdensome care is not required. So a year later, the Supreme Court of New Jersey determined that Karen Quillen could be taken off life support, and she actually on IV, or was it feeding tube. She remained alive for another 9 years. Ooh. 1983, Nancy Cruzan was driving home from work in a rainy night and missed a curve, crashed into like maybe a tree or something, was thrown from the car. Seat belts weren't required at that time. And again, she ended up in a persistent vegetative state. Many people are in a coma, and then they start to kind of wake up and they can thrash around. Their eyes could move, but they don't track. And again, the parents said, "Gee, Nancy, can we take Nancy off of her feeding tube?" She didn't need a ventilator, and this went all the way up to the Supreme Court, which indicated, yes, Nancy has that right to do that. But even though you're the parents, she's an emancipated minor, or she's an adult. And so the Supreme Court said you need clear and convincing evidence that she would not want to be left in this situation. Apparently, the parents were able to find some classmates who said, yeah, Nancy told them that she never wanted to be in a situation like this. So she was finally taken off the feeding tube and died 12 days later. But that was after 7 years of this very difficult situation. Terry Schiavo was another case. She again was 26 years of age. She was on a diet of, I think, tea or something, got some electrolyte imbalance and had a cardiac arrest, ended up in, again, a persistent vegetative state. And there's a back and forth between the husband and the parents in terms of a feeding tube, which was inserted, removed, like over a dozen times. Went to the state, actually went to the federal legislature. There was the Terry Schiavo law that was signed, but basically it ended up that she was able to be taken off the feeding tube, and she died 13 days later. So this led to several things, but probably most importantly, in 1990, the U.S. Patient Self-Determination Act, which says that adult patients may be informed that they have the right to refuse or accept treatment, and create an advance directive and appoint someone to make health care decisions if they are incapacitated. In 1994, the Oregon Death with Dignity Act, now, and various states have these that are generally called medical aid in dying, or MAID, was a ballot initiative that passed by 51%. But there's an immediate injunction stopping the implementation of this law, and and 3 years later, in 1997, there was another ballot measure to repeal this Death with Dignity Act, and it failed by 60%. And that same year, the appellate court indicated that this appeal was invalid. And so Oregon was the first state to allow medical aid in dying. That law has been the cookie cutter for many other medical aid in dying laws that are now available in those states. This last year, Delaware, Illinois, and New York were added to the list. Now I think it's 13 states and the District of Columbia. The medical aid in dying laws, generally speaking, are about the same. You have to be an adult 18 years of age or older. Resident of the state, yes, no, it depends. To be a California resident, you can come to California and rent an apartment or something, and uh, it's fairly well. Maybe it's not easy to come to California, but anyway, two physicians, and again, some states it's actually in California it's a physician, nurse practitioner, physician's assistant that agree there's an estimated 6 months life expectancy of the individual. They're mentally competent. They're able to understand what they're asking for. There's no coercion. There must be two separate verbal requests. Those verbal requests used to be 2 weeks apart. That's been amended, so it's like 48 hours apart. There's a written form to request medical aid and diet, this is all available at the California State Public Health website, and you just go through and download the form and have it witnessed by two individuals, and you must be able to self-ingest the lethal drugs. The California law says drugs, not medication. Okay, we'll just call it drugs. And they self-ingest. No one can really, no one can help them with ingest. And ingesting means putting it into the gastrointestinal tract. So some people who have a feeding tube, it can be put into a feeding tube. Medications or drugs can also be provided rectally. So there's details about that. If you follow the medical aid in dying steps, this is not considered by law suicide. It's not considered suicide, and physicians and others are not obligated to participate. Now, it's an interesting sort of thing in Canada, which has a population about the same as California, about 40 million. In Canada now, about 1 in 21 choose medical assistance in dying. 1 in 20, whereas in California, which has about the same population, about 40 million, it's about 1,000 that have each this last year have chosen medical aid in dying. In Canada, the Canadians are allowed to have a physician provide the lethal medication intravenously. That's called voluntary euthanasia. And that's been available in Canada since 2016. And the requirements are suffering from a grievous and irremediable medical condition. The matter of death being reasonably foreseeable was removed in 2021. So the difference is that Canada addresses suffering. The California and other state laws, suffering is not part of a criteria for medical aid in dying. Why do people in Canada choose that? Well, they have, I understand, some forms that can be completed, and these are generally felt to be the reasons why people choose, or Canadians choose, medical aid and medical assistance in dying. Unable to participate in activities that make life enjoyable or meaningful, loss of autonomy and independence, inadequate control of pain and suffering. These include things like profound weakness, nausea, shortness of breath, and then fear of future suffering and diminished quality of life, which again, that term, what does that mean? Why do people in California choose medical aid in dying? And those involved with this process, the physicians have to submit a report to the California Public Health Department of Public Health. And part of that form asks the physician to check boxes in terms of, why do you think this individual chose medical aid in dying? And the most common reasons are loss of autonomy, less able to engage in the activities that make life enjoyable, loss of control of bodily functions, inadequate pain control, and loss of dignity. Now, again, those are check boxes, and that's the current data we have. Several other states don't collect. I shouldn't say several. Some states that I've looked at don't collect such data. So we don't know why they chose medical aid in dying. So advanced healthcare directives, I'll touch on this briefly, but I'm sure this audience is familiar with this, but I want to highlight a couple sort of things. As you know, advanced healthcare directives differ a little bit in each state, and some feel that the legislative legal language has impeded its implementation. And again, certainly less than half, maybe a third of people complete an advanced health directive, and those that do so think it's all done. I don't think so. The Advanced Healthcare Directive has two main parts. I said here you can complete both parts or one part, and the other parts involve things like do you want to be an organ donor? Do you want an autopsy? Who's your primary care physician? But anyway, the two main parts are appointing a surrogate decision maker and alternate surrogate decision makers if that person is not available. That surrogate decision maker cannot be your physician or someone who works for the physician. But this term surrogate decision maker, there are like 9 other terms used for this, depending on which state you're in: healthcare agent, healthcare proxy, healthcare representative. And then part 2, sometimes called in some states a living will, asks, do you want or not want CPR, ventilator, tube feeding, or artificial nutrition? I must say someone I know says, we're discussing his advanced healthcare directive. He says, I was talking to him about artificial nutrition. He says, I don't want artificial nutrition. I want the real stuff. So some of this terminology is, again, somewhat ambiguous. Dialysis, transfusions, antibiotics, we'll go into that in a bit. I'll basically say that when these advanced directives were developed back in the 90s, Alzheimer's was not on the top 10 causes of death. Now it is, and Alzheimer's and dementia it is the biggest feared cause of death in this country. Now, the other part is these advanced healthcare directives, this is according to the National Institute on Aging, is legally recognized but not legally binding. Why is that? Well, it may not be followed because it's not available. It's unclear. It's oftentimes unclear. What does this mean? Decisions are complex and they are sequential. So okay, know this, know that. What about this? And then things keep moving along, and there's family disagreements commonly. There's conflicts also with healthcare providers, or in terms of healthcare providers' conscience or their own ethics. Healthcare institutions may also have policies that do not allow this, that, or the others. And generally speaking, it's not accepted, or what is accepted as healthcare standards, which again, you hear that term all the time, or at least I have, and it's a vague definition. What does everyone else do? And you don't want to be sort of sticking your head out. I want to point out a couple things. The California Statutory Advanced Healthcare Directive allows you to check 2 boxes, either choice not to prolong life or choice to prolong life. But frankly, in that first section and 3, it says, or 3, the likely risks and burdens of treatment would outweigh the expected benefits. Well, that's what we do all the time. We don't subject individuals to surgery. The surgeons really don't like patients to die in the operating room. So if the risks and burdens outweigh the benefits, then you're not going to get that. And then if you choices to prolong life within the limits of generally accepted healthcare standards, again, it's the way we practice medicine. So I think the Advanced Care Directive is really doesn't convey much useful information. This is standard medical care. Oh, I also mentioned that the California statutory advanced healthcare directive has a little box which says this goes into effect when two physicians or my physician has determined that I've lost capacity, unless this box is checked, in which case it goes into effect immediately. So my box is checked. My wife will make decisions for me if she sees that I'm not doing well mentally. She doesn't have to wait for the physician or physicians who are dragging their feet saying, gee, Tomita's, he's okay. So that's something to consider with this area of dementia, and something that I think most people are not aware of. I'm going to suggest people consider Prepare for Your Care. You can see it on the website, or you have to download it. It's free to download. It was designed or started by Rebecca Sidori at UCSF. She's a geriatrician and palliative care physician who's developed this advanced directive in simple, non-legalese language. She has this Prepare team that consists of attorneys and bioethicists and chaplains and a variety of others that have been working on revising and updating the Prepare for Your Care. She's gotten funding from the VA, the NIH, and from numerous foundations and nonprofits, so it's free. It's available in several languages. It has large font and has now explanatory videos, so you can click on those and hear in English or different languages what these questions are about. She also has now a Prepare for Their Care to help families or the surrogate decision maker. Families in the majority of cases are involved and not a surrogate decision maker, on what kind of questions do you want to ask? And those are, what are the benefits? What good things would come from this treatment? Oh, and I should say the advanced directives are designed in a hypothetical area, but then comes to the situation of someone facing surgery, this, that, or the others. And so these are the kind of questions you want to consider. What are the benefits? What are the risks? That is, what are the bad things that could come from this treatment? What are the alternatives? What does it look like in terms of quality of life after this treatment? Or again, what is the big picture? What does the future look like? What's the best case? What's the worst case? And what does this mean for quality of life? Quality of life, that's again comes up, but again, hard to describe. Now, even if you're not the assigned surrogate decision maker, you're encouraged to offer help, provide information to the care team as to what you've heard your friend, your younger brother, whatever's talk, or share with the anecdotes about what they consider to be quality of life, or what they would want or not want if they're unable to communicate those. And the healthcare team and the others are struggling with what to do. These are the sort of the general questions. What does quality of life look like for the person? Have they shared their medical wishes? What would they say if they could speak? What do you think they would say if they could speak? What is in their best interest at this time? And will medical options help them in terms of what they would consider to be a good quality of life? Advanced care plan takes time. It should be revised. And there are, again, a variety of articles, books, internet things. Death cafes are a venue where people come together and talk with strangers about issues around death and dying. And that can make it easier. Talking to your family or friends may be more difficult. And again, we're talking about situations where one is concerned about one's spouse or family member, and anyone can ask for palliative care consultation. You don't have to wait for the doctor or nurse to do that. You can also ask for a chaplain or social worker to help with difficulties that you're struggling with and information. 5 Wishes is another written in simple language advanced directive. It's available in several languages. It costs a little bit of money, and again, emphasizes where the emphasis is now is not so much do you want or not want CPR, but what do you consider to be an acceptable quality of life, and is been very popular as well. Another dilemma is where to keep your advance directive. And again, I think the current talk is, have your doctor have a copy, put it in your medical records, pass it out to those that are your surrogate decision makers. But oftentimes these advance directives are not available in an emergency. You're in Las Vegas or Reno or something, and so I'm going to suggest that the My Directives has been endorsed by several organizations, and several states now have suggested My Directives as a place where they will provide you with a wallet card, which has got a QR code as well as a URL, and you can have that uploaded to their website. I have one. It's in my wallet behind my driver's license. And on the reverse side, it has my wife's name and phone number and some medical information, and who to call if my wife's not available in an emergency. But that's one of several dilemmas in terms of trying to get the advance directive to the emergency folks when needed. Everyone's seen this before. People want to do well and just suddenly die. But most of the time, what we're addressing now is this issue of frailty and just dragging along and eventually dying. Here's one of the key points I think we want to think about. In early dementia, or even before you get dementia, it is helpful to include in your advance directive if you want to be hand-fed if you can't feed yourself. And this not being able to feed yourself is what occurs in late dementia. And in nursing homes and memory care units, many individuals are being hand-fed day after day. Also in your advance directive, this automatic, well, you want antibiotics. Well, antibiotics are commonly used for pneumonia, which used to be called the old man's friend, because people, as they lay in bed, unable to move about, they commonly develop pneumonia. They may not have a fever, but they have difficulty breathing, and that can be recurrent, as are recurrent urinary infections or other causes of infection. And sepsis or pneumonia used to be called the old man's friend because it's a relatively painless death. And again, if you're on palliative care and it's comfort is the focus, people can die of pneumonia or sepsis comfortably. There's been some talk about comfort feeding rather than avoiding hand feeding, and that's allowing someone to have a little bit of fluid and food. I've certainly heard some geriatricians talk about, that just really stretches out the dying process by months. And maybe, even though it's called comfort feeding, maybe that's a bit misleading. Or who's having the discomfort? Well, we can go into that a bit later. Okay, so this area of voluntarily stopping eating and drinking, or VSED, and again, there's a lot of information on the internet now, books, articles, etc. VSED causes death by dehydration, not by starvation, and it usually takes about 2 weeks. It can vary depending upon, well, a variety of factors. It requires supportive care, moisturizing the mouth, the lips. I've seen, well, we won't spraying some water into the mouth, little sips, ice chips. That just prolongs the dying process. But palliative care is important. The current talk is that persons with mild dementia who has mental capacity may initiate VSED and then may qualify for hospice and may then qualify for medical aid in dying. But this is a controversial area, but it's an area that currently society or those in this area are struggling with. Can you do VSED by an advance directive? We can go into some discussions about that. All right, let me talk about the Dartmouth Dementia Directive. It's one of several that are out there. And, Dartmouth and Ivy League School, they've been working on this for some time, and there have been revised versions. The most recent revised version has a whole section on consent for research. I've eliminated, well, that's part of the most recent version. Again, this is available online. And I think what's valuable is that they have this dementia severity rating scale, which allows the healthcare provider or even the caregivers to look at a variety of considerations. And this dementia severity rating scale involves things like looking at different domains, like memory, and then rating them. 0 for normal, 1 for occasionally forgets things that they were told recently. Altered memory does not cause many problems, some problems. Then mild, consistent forgetfulness through a variety of stages too. Does not remember basic things, recognize or remember when their last meal was. Other domains include things like speech. People with dementia have difficulty finding words, mixing up words, and eventually lose the ability to make sense or stop speaking. Recognizing family members is, again, something that is another domain that is looked at. Orientation to time, what day, what month, what week is it? And there are, again, orientation to place, where are they? And then, let's see, ability to make decisions. Decision making is slowed down, difficulty in that area, and there are actually all these other areas that the Dartmouth Dementia Directive allows people to kind of rate and consider. There's social and community activities, which with dementia people tend to start to withdraw from social participation, shopping, cooking, other kinds of home activities, personal care and cleanliness, eating, control of urination and bowels, and ability to get from place to place. These are all sort of rated in terms of normal, mild, not good. So depending upon your total score, you can be considered normal or mild dementia, moderate or severe dementia. And this dementia rating process has been developed by some folks at, as I recall, Harvard and University of Pennsylvania. And I think then it also avoids that step of you're concerned about this, who do you go to get an elaborate dementia testings, which, can vary from day to day or from even morning to afternoon or evening. So depending upon the stage of dementia, the Dartmouth Dementia Directive then has mild, moderate, and severe. What kind of medical interventions do you want? And those, again, range from from full treatment to comfort-focused treatment. Wow, I see I'm already at 11:38. I'll just move through some of this. The location of the care. Do you want to be in the hospital or not? Do you want nutrition and hydration, which we've touched on in terms of indicating that? Compassionate choices also has a dementia values and priorities tool, which focuses on values rather than do you want or not want CPR. And again, has a variety of questions that you can rate in terms of how you want to be treated if you have these different degrees of incapacity due to dementia. There are several of these sort of boxes. I'm going to skip those and tell you that we'll just move on to something called medical ethics, which basically has these 4 principles. First, do no harm, part of the people could call the Hippocratic Oath, even though it's not in there. And again, this black and whiteness is wrong. Every time we do something, there's risks and benefits. In our society, we emphasize autonomy. It's your decision. And then justice or allocation of resources is, I think, something that gets short shrift. Autonomy, free of influence? I don't think so. I think family influences people's decisions immensely, as does your community, your culture, your religious beliefs. Clearly legal matters determine where the line in the sand is. Healthcare providers impact that. Sources of information, belief, and how reliable they are. Mental capacity is also somewhat nebulous. And the emotional factors influence these tremendously. Oh, this is an aside. I'll skip this, but I think the diagnosis is an arbitrary definition by committee, and prognosis, again, is so difficult to make. So maybe medical advances have prolonged dying rather than extending a quality of life. Brain death, we won't go into, but is a topic we can discuss. And we're almost done, I think. Oh yeah, the same thing with the pulsed. Do you want a trial period of artificial nutrition, ambiguous term as it is? And I'm going to suggest that pulsed, MOLS, all these sort of terms remain ambiguous and not done. And I'd like to suggest that maybe ELMO, end of life medical orders, would be a more descriptive sort of term for these end-of-life choices. And to move the bar, it would be useful if anyone's interested in doing a survey, study, get that published, getting that out there into the literature will allow for some thoughtful discussion about this area. Okay, let's open up for some questions and discussion. I'm not sure I have some answers. I went through a lot of material relatively quickly. Okay.
Thank you, Dr. Tomita. I really appreciate this presentation. It really put a lot of things into context for me, and I really do appreciate that. If anybody has any questions for Dr. Tomita, you're welcome to put those into the chat. I wanted to share that Viva had shared that our San Diego County uses Prepare for Your Care. So they may be a social worker I'm kind of putting my own idea on what's going on here, but they may be a social worker that's helping people prepare their post and advanced directives. And then they also said sdcoalition.org is a community collaborative focused on supporting patients and families and navigating resources and support. So thank you for sharing those resources. I appreciate that.
And it's very hard for people to try to do this advanced care planning without the opportunity to engage in folks. So yes, I know Viva, and she's a great resource. So thanks for sharing those, Viva. And you don't have to do this alone, but it's useful to do it.
Dr. Tomita, I wanted to just ask you on a personal level, I had your bio and sort of your history. What brought you into the field of medical aid in dying and doing this as a volunteer job?
Even as an intern years ago, it was heartbreaking to have cancer patients suffering. I had one that was suffering and dying. And gee, can't you stop all this stuff? Huh, not on my shift. So this whole business of denying that patients are dying was that practice at that time. And then certainly during my career, we had individuals who were dying. But again, family were not allowing that and requiring that they remain conscious in pain rather than being allowed to be sedated, heavy morphine, whatever's to allow them to die peacefully. Certainly, one certainly been has experienced many people who've had lots of pain and suffering at the end of life. And again, I think it's one of the dilemmas or shortcomings of the current uh, um, advanced healthcare or medical aid in dying, and is that medical aid in dying is only for those that are mentally competent and don't address suffering. So hopefully that'll be, as we see that trajectory of where we've been, we'll get to society addressing suffering, which Canada's has done in other countries. So I read in the 1980s or something this book entitled Jean's Way by Derek Humphrey. He was a journalist with the London Times. His first wife, Jane, got breast cancer. And they asked Derek, gee, when the time comes, will you give me something to allow me to die rather than suffering and dying? And he wrote about that experience. I thought, makes sense. People should have the choice to do that. So I was involved with the Hemlock Society way back then, and feel that that's a civil rights choice, something that people should do. So it's one of those things. I've been involved with Planned Parenthood, which means I have one wife, no kids, to walk the talk as well. But I digress.
Dr. Tomita, I'm also curious, you mentioned earlier that sometimes some of the resistance that people have with medical aided dying is like, who are we actually making comfortable? Is it the family or the person who, is passing? I thought that was a very interesting. Is that something that you've encountered a lot in your practice as well?
Yes, that's always the situation. And it's a dilemma. Here you have maybe someone with advanced dementia who, smiles, doesn't look like they're in discomfort, but that's been the situation for 5 years. And it's depleted the family of, all their savings and everything else. And there's lots of stress. So who's suffering there? And by suffering, again, these are ambiguous terms, but there's this feeling that someone needs to suffer. So I think this focus on the individual really needs to be understood very commonly as it involves the impact on family, spouse, children, etc. So that's common. Oh, I should mention this in terms of the society struggling with this. Nevada, in their statutory advance directive, it was amended a few years ago, maybe 4 years ago already, that allows you to check a box that says, I choose not to have food and fluids. So the society is struggling with how to approach this end of life stuff and this idea of not eating, having no food and fluids is on the discussion, or maybe not, but it's part of the discussion.
Thank you for sharing all this, Dr. Tomita. Does anybody else have any questions for our presenter today?
I probably should have slowed down a bit. There's a lot to cover, but
No,
I'm not to do that.
I thought it was really great, Dr. Tomita, and I appreciate it. I worked in a nursing home for a while, and I had as a social worker and was doing the pulse with people, and it is so black and white in a way that it doesn't give all of the options and all of the context for what end of life care means, and it doesn't give it to you in a friendly way that makes sense, or like you were talking about with the artificial nutrition. I used to work as a dietitian and transitioned into being a social worker. So when I would talk to people about what artificial nutrition is, there was, kind of two reactions. One, like you were saying, where they're like, no, I don't want that. Or somebody would be like, oh, a feeding tube isn't a bad thing. So you have to color in all the different spaces there with the post sometimes. And I really appreciate you sharing all those different resources so people can understand advanced directives and what it all actually means.
Okay.
All right. Well, thank you everybody for joining us today. Dr. Tomita's information is here. We will send out that in a follow-up email as well if you have some questions that pop up. So thank you so much, everybody. Oh,
Thank
wait.
you.
Oh, I'm sorry. Wait, we do
Oh,
have one more question. I'm so sorry. There was one. Now I'm drawing us back in. Somebody asked how many patients use medical aid in dying while on a hospice?
I don't know. I understand the majority of people that utilize medical aid in dying are on hospice. There were again about 1,000 people in California last year, 1,200, whatever it was, that utilized medical aid in dying. So I'm going to assume the majority of those were on hospice. It's certainly encouraged, and by encouraged, there's a checkoff sheet for physicians to go through or nurse practitioners to go through, and it says, I've informed that they can change their mind even at the last minute. I've informed them that they can inform their family. They don't have to. Checkbox, don't ingest in a public place, things of that sort. Well, that reminds me, some, some hospitals, by and large, don't allow medical aid in dying. But what about your residential care facility? And I think one of the current issues right now is that's considered your home. And so even though some residential care facilities say, no, we don't allow that, there's some pushback in terms of is this your home and who's got rights, et cetera. I'm not sure how that's going to shake out, but that's one of the issues. Where can you ingest a lethal medication? Which also, I should say, the laws can change. Abortion laws have changed. And there's also concerns that defining medical aid in dying as not suicide is kind of a pushback.
Well, so that issue with the residential care, is that something that's being like debated, or is it something that's like how's that being handled right now?
I'm not sure. I've just heard that as part of the ongoing debate. I haven't heard of any lawsuits or things of that sort, but and again, the social acceptance of that. So people can be on hospice and uh, uh, you know nursing homes or residential care facilities, but if they're going to ingest and shorten their life, then uh, people have some concerns about that. That's where we are, I think, now.
Hmm.
And again, the whole aspects of voluntarily stopping eating and drinking by advance directive, or you've lost capacity, but you've expressed what you'd want if you got to the point, or suddenly. Again, we have people that have aneurysms and auto accidents or whatever's, and are left in a very impaired situation. What would they want done in that situation? And do you uh, address the individual's request then when they're not capacitated versus their, they talk about the then self versus the now self, and and besides that, how does the family work on this or decide on this, um, or agree to this?
Hmm. A lot to think about there, Dr. Tomita. I
Yeah,
appreciate that. Well, again, thank you. Oh, sorry, everything we almost keep wrapping up, and then another question pops in.
yeah, it takes a while to think through these things.
Yes. Somebody said NHDD is April 16th. Maybe the campus can help promote the importance of advanced care planning. Yes.
Yeah, not National Healthcare Decisions Day, April 16th, the day after tax day.
The day after tax day. Once you file that important paperwork, you can file the next set of important paperwork.
Death and taxes. Yeah.
Oh, death and
So
taxes. That's great.
yeah. So that's National Healthcare Decisions Day. How can we promote and encourage this prepare for your care kind of what's of value? Oh, and the prepare for your care is not only do you want not want this, that, and others, but why? There's questions about why, because I think it's thoughtfully gone through rather than just check, check, check this form,
Yeah.
And the other talk is about videotaping. New York just passed their medical aid in dying law, which requires not only the two doctors making the assessment, but also a psychologist or psychiatrist to determine their mental competency, and requires a video being done so that a video is done where you express. And again, I'm told a lot of communication occurs by tone of voice, facial expressions, etc. So rather than this form with check boxes, here's the father or mother saying in their own words, if I blah 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 blah. So interesting. Good. Good, by the way. I think it's useful to have that sort of inclusion, and should be done in your advanced directive here and uploaded to my directives.
Mm. Wow, I think in this question and answer section, you've really shown some of the ethical challenges and way people are sort of dealing with those ethical challenges with medical aid in dying. The video sounds very interesting.
I hope that'll
Okay.
become I hope that'll become
Yeah.
standard to do a video
Yeah.
template. Here's the questions to ask and consider.
Yeah.
Okay.
Okay, well, I am going to wrap it up now. I do thank you so much, Dr. Tomita, for your expertise and for sharing with all of us your resources today. We hope to see you again soon. And to everybody else, thank you so much for being here today. Stay well. Thank you.